In this video, we are going to discuss some of the highlights of our upcoming book chapter titled Evaluation and Treatment of Osteoporotic Fractures. Age constitutes an important factor for the loss of bone mineral density, leading to the development of osteoporosis and potential osteoporotic fractures. Vertebral compression fractures have been reported as having a negative impact on disability and quality of life, along with declining physical performance, especially in elderly people. The combination of an aging population and the adoption of a Western lifestyle in developing countries are resulting in an increase in the burden of osteoporosis worldwide. Rehabilitation is important through an exercise program to improve axial strength in order to maintain correct spine alignment and decrease in kyphosis. Medical treatment is an effective option in treating osteoporosis. However, the incidence of fractures remains very high, and although the best medical treatment can decrease fracture risk significantly, an important number of patients sustain fractures despite the medication. The technique known as vertebroplasty was used for osteoporotic vertebral fractures starting in the late 1990s. It has become the gold standard for addressing painful vertebral compression fractures. For diagnosis, MRI allows better accuracy in the assessment of classification compared to conventional radiographs. From a clinical point of view, there is no difference in outcome after kyphoplasty or vertebroplasty. However, a higher incidence of leakage has been reported after vertebroplasty than kyphoplasty. Zahn et al. Conducted a systematic review where the potential risk factors for cement leakage after vertebroplasty or kyphoplasty were studied. Authors suggested that patients with intravertebral cleft, cortical disruption, low cement viscosity, and high volume of injected cement may be at high risk for cement leakage after vertebroplasty or kyphoplasty. High viscosity cement is also used for vertebroplasty. A special cement delivery system, Stability, works with ultrasound and allows the application of ultra-high viscous cement, which helps to reduce the risk for cement leakage. High viscosity cement stabilizes the cement flow. The forces required for the delivery of high viscosity cement may approach or exceed the human physical limit of injection forces. Vertebroplasty was successfully extended to the treatment of metastatic lesions, where percutaneous vertebroplasty can be considered as a long-term effective treatment for consolidation of vertebral metastases. Another system that aims to restore height and reduce the risk for cement leakage, Kyva, was compared with kyphoplasty in an RCT and showed a similar clinical outcome but reduced rate of cement leakage. The techniques that are usually used are the following: vertebroplasty, stentoplasty, vesselplasty, shield kyphoplasty. In vertebroplasty, a filling cannula is inserted and the cement is directly injected into the vertebral body, whereas in kyphoplasty, a balloon is first inserted and inflated, then deflated and removed, thereby creating a cavity aimed at decreasing the risk for cement leakage. Both techniques have clinically meaningful beneficial effects on pain and disability, but kyphoplasty had significantly fewer cement leakages than vertebroplasty. In stentoplasty, height is restored and maintained by means of inserting and afterward expanding a vertebral body stent. It is comparable to kyphoplasty in terms of correction of kyphosis, time of exposure to radiation, and cement postoperative loss, and comparable to vertebroplasty in terms of restoration of vertebral height correction and cement bone volume. In vesselplasty and shield kyphoplasty, cement is injected directly into a permeable balloon to decrease the risk for cement leakage. The injection of acrylic cement into the vertebral body is characteristic of all these techniques. Talking about the fracture itself, each fracture needs to be assessed based on its individual fracture pattern and also based on the patient's individual situation. The standard classification for osteoporotic fractures proposed by Genent, that is in widespread use, addresses the morphologic criteria semi-quantitatively but is not able to provide clear guidelines for treatment. For trauma, the AO spine classification is based on mechanical stability. Most osteoporotic vertebral fractures are type A fractures, compression, and fit into the subgroup of the type A1. A certain number of these fractures may progress over time into a severe kyphosis. A follow-up radiograph can disclose a critical course easily. The progressive collapse usually occurs during the first 4 weeks. On the other hand, the appearance of a type A2 pincer fracture represents an important risk for further height loss because both end plates are injured. If a burst type A3 injury is present, the risk for a further collapse is high, so these injuries should be considered for surgical treatment. The initial imaging assessment should distinguish between simple compression fracture type A1 and complex fracture type A2 or A3. The following points can be helpful in assessing these fractures. 1. A standing film that can disclose the instability when comparing the image with an investigation taken in the supine comparing the loaded and unloaded conditions. 2. A follow-up radiograph that may show a stable situation or progressive vertebral height loss, which again would provide hints for further treatment. Age, previous fragility fractures at any location, low bone mineral density, and low body mass index are parameters that must be considered as risk factors. It was also demonstrated the radiological factors associated with persistent back pain after an osteoporotic vertebral fractures, considering also a T2 high signal changes in acute phase and old vertebral fractures as independent risk factors for residual back pain. This is the AO spine classification for thoracolumbar fractures, where we see A1, A2, and A3 compression fractures. In this slide, we will discuss the assessment and treatment algorithm for vertebral compression fractures. Patients with acute back pain, like thoracic or lower back pain, and an increased risk profile, older than 65 years, history of previous fracture, renal disease, steroid medication, body mass index below 20, should undergo an imaging investigation. The preferred examination strategy remains the standing radiographs of the region of interest in 2 planes. Comparing these radiographs to previous ones can often disclose a new fracture. A fracture of this kind can be followed easily through 2 consecutive controlled radiographs, which are usually performed within 1 to 2 weeks of the index image. MRI or CT is required to characterize the fracture pattern further in case of uncertainty. A bone scan can be used as a screening tool when the diagnosis remains unclear. Flexion extension views are not helpful in this context. The indications for treating vertebral fractures with cement reinforcement are based on the clinical problem and imaging findings and include the following. 1. Complex fractures, type A2 and A3. 2. Progressive collapse of vertebral body during follow-up control. 3. Multiple vertebral fractures within a short time period. 4. Painful fracture of a vertebral body refractory to conservative treatment, especially when requiring hospitalization because of pain. Avoid morphine as primary treatment for pain control in elderly patients. 5. Vertebral compression fractures associated with metastatic lesions and myeloma. 6. Internal fixation for improved implant anchorage. And finally, 7. Symptomatic vertebral body microfracture documented by MR imaging, nuclear imaging, and/or lytic lesion or lesions seen on CT scan without obvious loss of vertebral body height. There are obvious contraindications to treatment with cement reinforcement, including the following. 1. Fracture needing open surgical stabilization with screws and rods. Complex fracture with more than 30 to 40% spinal canal compromise. 2. Pain unrelated to the fracture. 3. Infection. 4. Neurological compromise with cord or nerve compression. 5. Fatigue fracture in ankylosed spines. 6. General contraindications to surgery. 7. Limited visibility during surgery or technical problems. 8. Uncorrectable coagulopathy. 9. Allergy to bone cement or opacification agent. Non-operative treatment of vertebral compression fractures includes analgesics and physiotherapy. The management options are pain relief with medications, short-term bed rest, bracing, or physical therapy, especially in the setting of an acute vertebral compression fracture. Pain medications is adapted according to the World Health Organization WHO scale and usually includes non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, acetaminophen, salicylates, calcitonin, or lidocaine 5% patch. Anti-resorptive treatment with bisphosphonates should be considered. Opioids should be used with care in elderly patients because of side effects. Calcitonin nasal spray seems helpful in the early phase. Concerning brace treatment, stiff braces are mechanically effective but not well tolerated. Other treatment alternatives, such as hydrotherapy, ice heat application, and acupuncture, are also presented in the literature. After the indication for treatment has been set, preoperative planning should start. Preoperative patient assessment includes a determination of normal coagulation status and sufficient respiratory and cardiac function. If patients can tolerate the prone position, they can be treated by the cement injection technique. If local anesthesia is used, patients must be placed in the most comfortable prone position. Positioning of the balloons and stents should be determined based on the CT or MRI for kyphoplasty and stentoplasty procedure. The preoperative images should be assessed to determine the pedicle size and orientation of the cannulas. For sedation and analgesia, propofol and fentanyl are adapted to the individual patient's needs and tolerance. An intravenous line should be established, and electrocardiography, oxygen saturation levels, and blood pressure monitoring should be established. Mild sedation is initiated by an anesthesiologist. The procedure is preferably performed under general anesthesia to allow for better patient monitoring. Vertebroplasty is most commonly performed in the angiography interventional radiology suite, and high-quality fluoroscopy is a prerequisite. Midazolam, fentanyl, or other medication may be administered to provide moderate sedation. Patients who are in severe pain may require general anesthesia to tolerate the prone positioning required for this procedure. The surgical steps for percutaneous cement injection are as follows. 1. Cannula placement. 2. Preparation of the cement. 3. Cement injection and cannula removal. The first step is the placement of the filling cannula or working portal. It can be either transpedicular or parapedicular. The approach at the thoracic and upper lumbar spine is generally performed monolaterally unless the fracture pattern is special or unless a kyphoplasty or stentoplasty procedure is planned. In the lower lumbar spine, the approach is usually transpedicular and carried out bilaterally. This results in the achievement of sufficient filling and support for the vertebral body. Image-guided navigation is the base for any percutaneous procedure. The standard method is the C-arm. High-quality equipment is required. A combination of two C-arms can ease and thereby speed up the procedure, although this is not mandatory. Stills reported the results of using the O-arm guidance system to perform balloon kyphoplasty in 54 consecutive patients, where he measured X-ray exposure and fluoroscopy time. It was found that the overall surgical and fluoroscopy times are reduced using this technique of imaging instead of CR. The individual steps for cannula placement are the following. 1. Informed consent and time out are obtained. 2. The site to be treated is examined with the C-arm, ensuring that the anatomic landmarks are clearly visible in both planes. 3. The levels and options of entry are indicated. 4. Disinfection and surgical draping are performed. 5. The C-arm is introduced in strict anteroposterior projection. The beam is adjusted parallel to the end plates, and the pedicles are identified. If the fracture end plate cannot be seen properly, the adjacent end plates should be used. 6. Local anesthesia is injected into the skin in the projection of the pedicle and around the periosteum of the transverse process and facets, about 5 ml. 7. A stab incision is made according to the planned trajectory. 8. A 2 mm guide wire or directly cannula is placed stepwise. When the guide wire tip touches the bony surface, the starting point is usually lateral to the outlines of the pedicle in the upper zone, thus achieving sufficient convergence. If a monolateral approach is chosen according to the preoperative planning, the starting point is located up to 1.5 centimeter lateral to the pedicle eye. The guide wire is advanced under anteroposterior image intensification until its tip reaches the medial border of the pedicle. If more than one approach is necessary, this step is repeated. 9. The position in the lateral projection is checked, and it is ensured that the tip of the K-wire or cannula is at the level of the posterior wall. 10. If necessary, the position of the guide wire is readjusted. 11. The filling cannula or working portal is introduced. The tip of the filling cannula should reach the anterior half of the vertebral body. 12. A biopsy is performed if needed. 13. A blunt trocar is used to clear the cannula and create a small free space in front of the cannula. Several cement formulas currently available on the market are especially designed for vertebroplasty. Increased radiopacity and longer working time at the optimal viscosity level. Some of these cements are ready for immediate use, such as confidence and stability. Awareness of the temperature sensitivity of the setting time is of greater importance. High viscosity is the most crucial factor for controlling cement leakage. It is not recommended to use self-made cement formulas. If possible, one should use the same cement type for each procedure to become familiar with its individual setting behavior. Bone cement, or PMMA, is an inert biomaterial that has been in use in orthopedics for more than 50 years for the anchorage of artificial joints, for filling bone defects and tumors, and for the stabilization of the spine before moderate implants was available. Adding mineralized collagen to the PMMA improves the outcomes by reducing pain and the rate of reoperations, in addition to forming a stable structure in the vertebral body. Alternative materials, such as calcium phosphate cements, are available despite being difficult to handle. Low viscosity cement should not be injected. The steps for performing cement injection are as follows. 1. The cement is prepared and injected after it has reached the desired viscosity. 2. Cement injection is carried out under continuous lateral C-arm control with intermittent anteroposterior imaging checks. The filling is performed slowly in 0.5 ml steps. 3. Injection must be stopped whenever any cement leakage is observed. Injection can be resumed after 45 to 180 seconds, depending on the type of cement used. It is hence important to check the clock regularly. 4. The filling procedure is continued until the vertebral body is supported from the upper end plate to the lower end plate and to the stable area of the vertebral body. The amount of cement is variable. At the thoracic spine, the volume is about 2 to 5 ml, and at the lumbar spine, it is up to 10 ml. The volume needed is determined by both the degree of porosity and the amount of height loss. 5. The cannula is removed and the stab incision is closed after the cement has set. The application of PMMA to increase the stability of implants has been used for a long time. Vertebroplasty is done to increase the stability of the screws inserted before the cement has set. Perforated screws allow for direct cement injection through the screw, thus improving stability. The amount of cement required for improving stability is between 1 and 4 ml per screw. Certain cements are available with a very long working time. This allows for safe cement injection through 4 screws in one run. To decrease the number of vertebral compression fractures that occur after fixation, prophylactic reinforcement of the vertebra next to the fixation level can be carried out. Fixing an increased number of levels raises the risk for a fatigue fracture following stabilization. This should be considered especially with scoliosis correction in elderly patients. Common problems include fractures of adjacent vertebra and failure of the last instrumented vertebra. Failure may occur despite cemented screw fixation and the prophylactic augmentation of the adjacent levels. If the patient can tolerate any additional cement, adjacent level injections can be performed during the main intervention. In this case, both the main procedure and the percutaneous injection are performed under the same anesthesia. Alternatively, the patient can be treated secondarily under local anesthesia during the early postoperative phase, typically after 1 to 3 weeks. Adjacent fractures are usually observed within the first 4 weeks after surgery. In this section, we will discuss the controversies of vertebroplasty. Buchbinder et al. Studied in their RCT the effect of vertebroplasty for painful osteoporotic vertebral fractures. The participants who had 1 or 2 painful osteoporotic vertebral fractures were randomly assigned to undergo vertebroplasty or a sham procedure. No beneficial effect of vertebroplasty as compared with a sham at 1 week or at 1, 3, or 6 months after treatment. The majority of patients with acute or subacute painful osteoporotic compression fractures in the spine may recover after a few months of conservative treatment. Kalmes et al. Did an RCT where 131 patients were diagnosed with painful osteoporotic vertebral compression fractures. planning to undergo either vertebroplasty or a simulated procedure without cement. Authors found the improvement in pain and disability to be similar in both groups. Rounzing et al. Compared the percutaneous vertebroplasty to conservative treatment in patients with osteoporotic vertebral fractures. They found that while percutaneous vertebroplasty technique might provide a useful alternative for some patients, the majority of fractures healed after 8 to 12 weeks of conservative treatment with subsequent decline in pain. Most cement leaks are not clinically relevant. However, both cement embolism with a lethal outcome and cement leakage into the canal with subsequent spinal cord compression and paraplegia have been reported. Misplacement of the cannulas. Misplacement of the cannulas can injure a nerve root or even the spinal cord. Vascular injury may occur with anterior perforation of the vertebra. Using a guide wire allows for easy navigation and change of orientation and is also helpful in large diameter cannulas are used. Cement leakage. Avoiding this complication primarily entails being aware of the potential risks and understanding the basic principles of injection biomechanics and rheology. The most important factor in leakage is cement viscosity. Only high viscosity cement should be used for the procedure. Only large cannulas, like 8, 10, or 12 gauge, should be used. The safest and simplest way of injecting cement is to use small syringes or a plunger system that also allows for the injection of very pasty cements. Cement behavior and duration of working time are important aspects. If any leakage is observed, the injection must be stopped immediately. The injection can be resumed after waiting 1 to 3 minutes depending on individual cement characteristics. Sometimes this approach of trying and then waiting needs to be repeated. If the leakage cannot be controlled, the injection must be stopped. In severely osteoporotic patients, injecting the adjacent levels in a prophylactic manner seems justified with a very limited risk for cement leakage. Adjacent fractures. Leakage in the disc space, especially in complex fracture types, is not dangerous in itself, but may provoke a higher risk for an adjacent fracture. Patients with severe osteoporosis who undergo a spine stabilization procedure for any reason have a high risk for an adjacent fracture, especially if the stabilization is enhanced with cement reinforced screws. Mechanical failure. Mechanical failure may occur after vertebroplasty if the initial cement filling was not sufficient and a further collapse is occurring. More frequently, the failure is seen in the treatment of non-union in patients with pincer type A2 fractures, which typically occur at the thoracolumbar junction with dislodgement of the cement plug and loss of stability. If an insufficient filling is the cause of the problem, repeating the vertebroplasty procedure can be helpful. However, in the case of dislodgement of the cement plug, surgical stabilization with screws and rods should be considered. Finally, infection. In our experience, over a time period of 15 years and more than 4,000 patients treated, no infection came to our attention. A recent survey from Germany reported infection in 6 out of 1,300 patients, including tumor patients. The treatment varies. In addition to antibiotics, debridement and mechanical stabilization may be performed when needed. As a conclusion, vertebral compression fractures occur in patients with osteoporosis and frequently lead to back pain. The most common surgical options are kyphoplasty and vertebroplasty. The bone cement reinforcement restores the vertebral height, improves the pain, and prevents the refracture of the affected and adjacent vertebra. And some of the surgical complications include misplacement of the cannulas, cement leakage, adjacent fractures, and mechanical failure and infection.